Hello and welcome to the Endocrine Society ENDO 2021 Virtual News Conference on Cancer. My name is Colleen Williams and I'm the Public Relations Manager here at the Endocrine Society. Before we get started, I'd like to just go over a couple of quick housekeeping items. Journalists may type their questions into the chat window at any point during the news conference, and they will be addressed during the Q&A, which we'll have at the very end. Please be sure to include your name and affiliation with your questions. This press conference is being recorded, and recordings will be available on endowebcasting.com, the Endocrine Society's YouTube channel, as well as our website following the presentations. Today, we are very pleased to have with us Dr. Xiaoxiao Wang of the Beckham Research Institute of City of Hope in California, Dr. Giovanna Piccoli of the Federal University of Rio Grande do Sul in Brazil, and Professor Caitlin Murphy of the University of Texas Southwestern Medical Center. Over the next 30 minutes, each speaker will present their findings, and then we will end with a Q&A session. I would now like to invite our first presenter, Professor Wang, to speak.
Well, so thank you, Colin, for your introduction, and also thanks for the Endocrine Society invite me. So it is a great honor for me to share our study on white bottom mushroom and prostate cancer. So this study was done under the mentorship of Dr. Xuan and City of Hope, the leading scientists on the mushroom project, and I present the study on behalf of our team. And I have nothing to disclose. Next slide, please. So the current study was based on a clinical phase 1 trial previously conducted at the City of Hope. So as shown in this cartoon, in this trial, and we observed that for prostate cancer patients with rising PSA levels in their blood circulation, and simply by oral intake white bottom mushroom powder can help to reduce or lower the PSA levels in their blood circulation. So it doesn't matter what we found. Why it matters? So here the same. Prostate cancer, according to the number from American Cancer Society, is among the most common cancer in American men. About 1 man in 8 will be diagnosed with prostate cancer in his lifetime, while the PSA, short for prostate-specific antigen, is the indicator of the cancer. So in most of the cases, rising PSA in blood circulation indicates that a tumor is growing in prostate gland. So therefore, for men over 50 or for prostate cancer patient under treatment, it is essential to keep close eyes on their PSA level. And men also need a simple, safe, and effective way to bring the PSA level down, help to prevent or to slow the progression of prostate cancer. So as we found that white bottom mushroom, the common food you find at the supermarket, you add into your salad and the pizza, can do this job. Is that great news that you want to share with your family right away? Like by telling your grandpa or your father that eating more mushroom is good for your prostate health, right? So, but the common question is going to be why and how mushroom can do this great job. And we can't simply answer by magic, right? So by asking this simple and straightforward question, and I designed the following study and in the hope provide the public an answer. The next slide, please. So I use mice-bearing human prostate tumor as a research model. Technically, I implant the human tumor into the mice. For those mice growing a human tumor, they will be treated as tiny patients in the lab, and I feed them mushroom extract at the treatment. And a comparison, the other group of mice received azalutamide treatment. It is FDA-approved drug for prostate cancer tumor. And then for the mice in control group, they just receive placebo feeding. So as you can see from the tumor growth curve in the upper image, and the tumor under the placebo feedings continue to grow during the treatment course, while the tumor under mushroom treatment keeps shrinking. And the shrinkage induced by mushroom feeding was as great as that induced by azalutamide. And the endpoint of tumor size and show in the bottom image, under mushroom treatment, the tumor size was much smaller than the tumor in the control mice. And then we take surgical remove this tumor and slice them into like tiny, very thin layer and stain them with different colors. And with this method, we're able to look into the tumor tissue and analyze the responsiveness of the tumor to the mushroom treatment. And we also choose the same diagnostic markers that pathologists and oncologists be using to the patient biopsy sample, those including the androgen receptor, the key drive factors for prostate cancer growth, and PSA, and the indicator of the tumor growth, and Ki-67, and it's a growth index indicating how fast the tumor is growing. So simply we display those markers by brown color, and we look and compare the location and intensity of the brown color. And the higher or strong staining of the brown color indicate that the higher amount of those markers in tumor, while the treatment try to bring down the color. Therefore, the growth of the tumor can be like restricted. So as you can tell from the image on your right hand, that mushroom treatment like very clear, bring those brown color down within the tumor. So this observation from human tumors like is encouraging and informative, but it's not enough to draw a clear roadmap and explain how mushroom do this job. And then I decide to dig deeper and zoom into the cancer cell. So next slide, please. As shown in, we mentioned before that estrogen receptor is a key factor driving the prostate cancer growth. So as shown in this cartoon, so once estrogen receptor being active in the prostate cancer cells, and they're going to move into the cell nucleus and start take action by activating a couple of genes and therefore drive the cell growth, also including the PSA production. So if we take cancer cell as a racing car, the estrogen receptor is going to be the gas pedal, and the PSA is going to be the speedometer. So the harder you press your gas pedal, the faster your car goes, right? In the same principle. So the more estrogen receptor to be active and located in the cell nucleus, the faster the tumor grows and more PSA will be produced. So with this idea, and then back to the image on your left hand. So I technically grow the human prostate cancer cells on the dish, and I label the estrogen receptor with green color. And then I display the cell nucleus with blue color. And you can tell when we give the mushroom extract treatment to these cancer cells, and cells start to lose the green color, which means the estrogen receptor activity being expressed under the mushroom treatment. And in other words, like mushroom help to release the gas pedal and therefore slow down the tumor growth and produce less PSA. So till then, and we're able to draw a clear roadmap as shown in this cartoon that explains how mushroom could do this job, help to slow down the progression of cancer and also lower the PSA production. And we are able to have this study published on Journal of Nutritional Biochemistry. But our innovation and on mushroom the cancers never end at City of Hope. So next slide, please. So the City of Hope research on mushroom was initiated and led by my PI, Dr. Shen Chen, and date back to 20 years ago. He's among the first discovered that white bile mushroom can block sex hormone action. And City of Hope is also a unique and supportive organization that we're able to like seamlessly translate what we found in the research lab into potential patient care interactively. And that's how we can process our research pipeline from preclinical study all the way down to phase 2 clinical trial. And now funded by the National Cancer Institute, we have initiated a phase 2 clinical trial with large number of prostate cancer patients, and in the hope that confirming the positive and healing effect of white bile mushroom on people with prostate cancer. The next slide, please. In conclusion, so the take-home message from my study for the public going to be the answer to the question we asked at the beginning: why mushroom could help to slow down the progression and reduce the pH level. So here the conclusion: white bile mushroom chemicals in white bile mushroom could disrupt the androgen receptor signaling pathway, the key factor drive the prostate cancer tumor growth. Therefore, help to lower the PSA level and slowly or to prevent the progression of cancer. So I would like to take your question and Q&A session, and thanks for your time. Thank you.
Wonderful. Thank you so much, Dr. Wang. I would now like to invite Dr. Piccoli to present her research.
Thank you, Colleen. And I would like to thank the Endocrine Society for this invitation. Next slide. So in a systematic review with meta-analysis, we found that glucagon-like peptide-1 receptor agonists as a therapy for obesity and diabetes do not increase the risk for the development of breast cancer and benign breast neoplasms. Next slide. So why this is a concern? Type 2 diabetes and obesity are two related conditions that raised epidemic proportions globally, and both are associated with increased cancer risk. So maybe we can think that glucose and weight control could address this risk. Next slide, please. So glucagon-like peptide-1 receptor agonists are effective drugs to active glycemic and weight control and have a potential on cardiovascular risk reduction. These drugs reduce food intake, slow gastric emptying, have an action in appetite center, increased glucose-dependent insulin secretion, and all of that without hypoglycemia. Next slide. So in this scale, a trial about liraglutide versus placebo in patients with obesity and prediabetes, there was an imbalance in incidence of breast neoplasms between groups. In the liraglutide group, there were 15 events versus 3 events in the placebo group. Most cases occurred in the first year and in participants who lost more weight. So this raises a concern about the relationship between GLP-1 receptor agonists and cancer risk. Next slide, please. So our objective was, as I said, that available data raised the concern that GLP-1 receptor agonists might increase the risk of breast cancer. So we performed a systematic review and meta-analysis with trial sequential analysis to analyze this possible relationship. Next slide. So we included randomized controlled trials in participants with type 2 diabetes, prediabetes, overweight, and obesity treated with GLP-1 receptor agonists versus placebo or active treatment. The main outcome was benign and malignant breast neoplasms, and minimum follow-up was 24 weeks. Next slide, please. About the results. So we screened 6,972 records and included 52 trials in the analysis. About subtype of GLP-1 receptor agonists, as you can see, there was liraglutide, semaglutide, albiglutide, lixisenatide, exenatide, and dulaglutide. As you can see in this slide, there was characteristics about the studies included, and I emphasize that the follow-up was between 24 weeks and 70.5 years. Next slide, please. And we found no association with breast cancer incidence. So in the GLP-1 receptor agonist group, there was 130 breast cancer cases versus 107 in the control group, or in the placebo and active drug versus GLP-1 receptor agonists. The relative risk was 0.98. Next slide, please. We also analyzed in 11 trials the benign breast neoplasms incidence, and also there was no difference between the group treated with GLP-1 versus placebo or active treatment. A secondary analysis by follow-up, by molecular type, by GLP-1 agent, and by open label versus double blind trial was performed, and no difference in breast cancer incidence between groups was found. we performed a trial sequential analysis to evaluate if our sample size was sufficient for the certainty of these results. And in this TSA, we found that a required sample of 65,000 individuals were necessary. And in this meta-analysis, the breast cancer meta-analysis, we included 89,000 participants. So it's more than sufficient. Next slide. So in conclusions, glucagon-like peptide-1 receptor agonists were not associated with breast cancer and benign breast neoplasms, and can be used as adjunct to exercise, diet, and other drugs to treat people with obesity and pre-diabetes. Next slide. I thank you for your attention.
Thank you very much, Dr. Piccoli. I'd now like to invite our last speaker, Professor Murphy, to present.
Thank you all for the opportunity to discuss our work. Now, in full disclosure, I am a cancer epidemiologist and not an endocrinologist. And so my motivation for this study was to understand the rapidly increasing incidence rates of early onset cancers, broadly defined as any cancer diagnosis before the age of 50. Next slide. Before I get into more detail and background, I want to start by highlighting our key findings. We found that exposure in utero or in the womb to a drug that is used to prevent miscarriage may increase the risk of cancer in adult offspring many decades later. Specifically, some adult children of women who received a drug called hydroxyprogesterone caproate, or OHPC, during pregnancy in the 1950s and 60s are now experiencing more than twice the odds or the risk of cancer. These findings provide compelling evidence that some synthetic or man-made hormones cause endocrine disruption during early fetal development and may contribute to cancer later in life for the offspring. Importantly, OHPC is still available today, marketed under the trade name Makena, to prevent preterm birth in pregnant women. There is remaining uncertainty about the risks and benefits of this drug, especially when considered alongside our findings. Next slide. Now, by way of some additional background, I described my motivation earlier for this study as understanding the rapidly increasing incidence rates of early onset cancers. And so on this and the next few slides, I've plotted incidence rates of certain types of early onset cancers over the period 1992 to 2017. Again, an early onset cancer is broadly defined here as any diagnosis before the age of 50. On this slide, you can see that rates of colorectal cancer, typically a cancer we think of as only affecting older adults, have gradually increased in younger adults, such that the incidence rate in 2017 is almost double what it was in 1992. Next slide. Rates of other types of early onset cancers are also increasing, including uterine cancer, shown here. Next slide. Kidney cancer, next slide, and thyroid cancer. It's clear that increasing incidence rates are not limited to one particular type of cancer, but many types of cancers, not necessarily related, are all increasing in this younger age group. Next slide. These patterns of incidence rates made us think about exposures or risk factors in very early periods of life, like gestation and infancy. For example, there were many drugs given to pregnant women in the 1950s and 60s, and the use of those drugs parallels the increasing incidence rates of cancer in young adults. One such drug was hydroxyprogesterone caproate, or again, OHPC, which was a synthetic progestogen initially approved in 1956 to treat spontaneous or threatened abortion in pregnant women, marketed under the trade names Proleutin and Delalutin. OHPC doesn't have a very clear regulatory history, but we do know that it continued to be used after its approval in the 1950s until sometime in the early 2000s, when the FDA withdrew their approval, not citing any concerns of safety or effectiveness, but simply because it was no longer being used or marketed. Importantly, OHPC was reintroduced to the market in 2011 under the trade name Makena to prevent preterm birth in pregnant women who have previously had a preterm birth. Makena has continued to be the subject of some controversy, and as recently as October of last year, an FDA committee recommended withdrawing their approval based on no evidence of a clinical benefit observed in 2 randomized trials. Yet, despite this recent controversy and the fact that OHPC is still used today, we know very little about its long-term effects on the health of adult offspring, particularly those who may have been exposed in the womb when the drug was first used in the 1950s and 60s. Next slide. As you can imagine, it can be challenging to study exposure to a drug in utero and the risk of cancer many, many decades later. But fortunately, in the United States, we have a multi-generational study that allows us to do exactly that, the Child Health and Development Studies. This is a unique and diverse cohort of about 14,000 women who are receiving prenatal care in the Kaiser Health System in Oakland, California in the 1960s. Very detailed information was collected prospectively on maternal conditions before and during pregnancy, all medications received before and during pregnancy, and then during labor and delivery. Importantly, these data can be linked with the California Cancer Registry to identify new cases of cancer diagnosed in the women's offspring, and for a period of follow-up that extends more than 50 years after they were first born. You can see here that through December of 2018, we've identified 954 incident or new cases of cancer in adult offspring. Next slide. About 1% of mothers in this study received OHPC in early pregnancy. So it wasn't a very common drug in pregnancy, but certainly we can see that it was used during this time. Common indications included, not too surprisingly, threatened abortion, amnionitis, and incompetent cervix. In utero exposure was more common in offspring who were later diagnosed with cancer in their adulthood, among whom 18 cancers were diagnosed, including, among others, colorectal cancer, melanoma, and breast and prostate cancer. Next slide. This figure shows odds ratios or the association between in utero exposure to OHPC and cancer in adult offspring. And I want to point out a few specific numbers to you. Next slide. First, the risk of any cancer or all cancer types combined was twice as high in offspring who were exposed to OHPC in utero compared to those not exposed. Next slide. And this overall effect seems to be really driven by a striking association with colorectal cancer. Here you can see that offspring exposed in utero had nearly 5 times the risk of colorectal cancer compared to those who were not exposed. Next slide. To wrap up and summarize, these findings suggest that multiple organ systems are susceptible to endocrine disruption in early development. In utero or exposure in the womb to OHPC may contribute to the increasing incidence rates of certain cancers in young adults, particularly early onset colorectal cancer. Even before we understand the exact mechanisms behind this elevated risk of cancer, caution using OHPC in early pregnancy is warranted, especially in the absence of a clear short-term benefit and given the possible effect on risk of cancer in adulthood, as I've described to you here. Thanks very much for your time, and I look forward to your questions.
Thank you very much. Those were awesome presentations. Now I'm going to turn it over to my colleague Jenny to start the Q&A.
Great, thank you, Colleen. Dr. Wang, I was wondering, since this is still early in the research process, for folks who are at risk of prostate cancer or are being treated for prostate cancer, is there any value in them adding white button mushrooms to their diet?
Well, that's a great question, actually. Our colleague here also discussed about. So from my presentation, you learned that our research actually is still ongoing. And we have finished clinical phase 1 trial, and we carried out several preclinical study and the reverse translational study, and to confirm the positive and the healing effects of white button mushroom on cancer patient. But I would like to say that it's still a little bit earlier to like translate the our finding into patient care. And that's why we have initiated the phase 2 clinical trial, and we're working on the phase 2 trial with large number of patients. And we're seeking in hope that we can confirm the effective and also the safety of white bile mushroom on the patient care. So if we can get like positive and encouraging result from phase 2 trial, that's going to give us lots of hope. Thank you.
Thank you. Great. Dr. Piccoli, have you or heard in your practice have patients, because of the earlier research that found a potential link to cancer, were there concerns from patients about using GLP-1 medications in the past? And how do you think your findings change that landscape moving forward?
Thank you for this question. Yes, GLP-1 receptor agonists in previous studies were associated in vitro studies with pancreas cancer and medullary thyroid cancer, and patients and also doctors were preoccupied about that. Breast cancer is in the same way. So I don't know if patients know about the results of the SCALE trial, because it's not in the main paper, it's in the adverse reactions, but I'm sure that the results of our meta-analysis adds more security and safety information about this treatment, and patients and doctors and all health professionals can be more secure of this, the safety of these drugs.
Great, thank you. I have another question for you from Chris Dessat with the Brazilian Endocrinology and Metabolism Society. She asks, do you believe that GLP-1 analogs offer no risks for women with a previous history of breast cancer?
Oh, unfortunately, we cannot say that, because in this meta-analysis, we included participants in randomized controlled trials, the most important randomized controlled trials, but in the majority of these trials, breast cancer or another cancer were exclusion criteria. So this population were not available. The data about this population were not available. The majority of patients in these randomized trials and in this meta-analysis is participants without neoplasms, without cancer. So we cannot say that. We can say that in general population with type 2 diabetes and obesity, it's safe, but not in patients with breast cancer.
Okay, thank you. Dr. Murphy, since OHPC is still available here in the United States, how big of a concern is ongoing exposure?
I think we have to take a step back and realize there are a couple of key differences between the drug that's used today and the drug that was used in the 50s and 60s. Even though they are the same ingredient, they did have a different indication and a different timing associated with that indication. So in our study, we looked at use during very, very early pregnancy, so days 0 through 140 of gestation. But today, the drug is not recommended until at least 16 weeks of gestation through weeks 37. That being said, I think the evidence that we've shown here is another piece of information that women should consider when weighing the risks and benefits of taking this particular drug.
Great, thank you so much. That's all the questions we have in the queue.
Great, thank you, Jenny. So with that, we'll wrap up here and just say, once again, thank you so much to our speakers and all of the journalists that joined us today for this great discussion. As a reminder, these news conferences will be available on our website and YouTube channel. And if you have any questions or would like to set up an interview, please don't hesitate to reach out to us at media@endocrine.org. Thank you again.